Myelodysplastic syndromes. Etiology. The etiology of most cases of myelodysplastic syndrome, MDS, is unknown. However, in a proportion of cases there is an obvious associated factor. Exposure to benzene, ionizing radiation, and organic chemicals. Previous cytotoxic chemotherapy, e.g. alkylating agents and procarbazine. The median time to development of MDS in these cases is 4–5 years. Certain genetic disorders may predispose to MDS, e.g. Down syndrome, Fanconi's anemia, and neurofibromatosis type 1. Epidemiology. This is largely a disease of the elderly, median patient age, 69 years. In those of the population over 70 years of age, the incidence is greater than 30 per 100,000. The incidence is very low in those under the age of 50, with no recognized predisposing factors. Males are more commonly affected than females. Clinical presentation. About 1/4 of patients will be diagnosed following an incidental finding on the blood count. Most patients present because of features of bone marrow failure, 80% due to anemia, 20% due to the consequences of neutropenia and thrombocytopenia. Investigations. The diagnosis is usually first suspected from the blood count and film. FBC may show pancytopenia, anemia, or isolated cytopenias of other lineages. Macrocytosis, mild, may be present. The blood film shows dysplastic neutrophils, Fig 30, and odd-looking platelets. Blasts may also be seen, Fig 31. Bone marrow aspirate and trophine are crucial for the diagnosis of MDS in any patient in whom treatment would be contemplated. In an elderly patient, where management would not be altered, this need not be done. The marrow is hypercellular in most cases. All three lineages may show abnormalities. Ring sideroblasts, due to abnormal iron accumulation in the mitochondria, may be seen on Pearl stain, Fig 32. Chromosomal abnormalities are common, particularly in the group with MDS related to previous cytotoxic chemotherapy. Autoantibodies are found in up to half of the patients. Classification. The current World Health Organization, WHO, classification is shown in Table 19. Treatment. NB. MDS is a classic example of a disease where active treatment may be the wrong choice. The vast majority of these patients are elderly and many have other medical problems. Taking the quality of life into account is essential, and treatment should be tailored to best suit this objective. More aggressive approaches will be indicated in younger, fit patients. Supportive care. This is the approach taken in the majority of patients. Red cell transfusions should be given according to symptoms. Remember that iron chelation with desferrioxamine may be indicated in patients who are recurrently transfused, but this is only really indicated in a patient in whom very long-term transfusion therapy will be indicated. Platelet transfusions should be reserved for bleeding complications or prophylactically for procedures. Antibiotics are given as needed. Growth factors. These can be used in the short or long term and include erythropoietin and granulocyte colony stimulating factors. The latter can be helpful in increasing the number of neutrophils and improving their function in patients with infections in the short term, and may therefore reduce the duration of their hospital stay and antibiotic treatment. Growth factors used in combination can cause an improvement in blood counts in certain patients, thus reducing the transfusion requirements, but survival benefit is not yet proven. The cost of such regimens remains high. Immunosuppression. There are data to support the use of immunosuppressive regimens, anti-lymphocyte globulin and cyclosporin, in certain patients, particularly those with a hypocellular bone marrow. Clearly, the patient's general health and the side effect profile need to be considered. Cytotoxic chemotherapy. Cytotoxic chemotherapy ranges from palliative treatment with outpatient regimens to aggressive combination chemotherapy with acute myeloid leukemia, AML, type regimens. Transplantation. Allogeneic transplantation can be recommended in a proportion of well-selected fitter patients, and this can offer a long-term event-free survival rate of up to 50%. Prognosis. All patients with MDS have a reduced life expectancy. The International Prognostic Scoring System stratifies patients according to the number of blasts in the bone marrow, chromosomal abnormalities, and the number of cytopenias. Patients will fall into low, intermediate or high-risk categories. On the basis of this, median survival is more than 10 years in low-risk patients but less than 6 months in high-risk patients. The risk of transforming to AML is 20% at 10 years in low-risk patients but 50% at 3 months in high-risk patients. Patients who do not transform to AML will usually die as a result of the effects of bone marrow failure.